So we are recording and you can start.
Okay. I'm trying to minimize the disturbance to the screen. I think now it's better. The screen is better now.
Yes, sir. You can start.
Okay. So good afternoon, and I'm delighted to be participating in the UR-FOXY Visakhapatnam South Zone Conference, which was supposed to be in 2020, and I was there to be in person, but unfortunately this could not happen because of COVID. So I'm delighted to participate in 2021 and like to thank Professor Radha Tatapudi, Subaraju, and Radha Puduri for their kind invitation for me to give this talk. So my talk is on migration from partogram to labor care guide. The objectives of my talk is given here. I have no declaration of interest, and I would like to acknowledge the help of Olufemi Metin Mercedes from WHO and Tina Lavender from Liverpool, who gave me a hand in preparing this talk. So the objectives are, why should we consider the issue of migration to labor care guide? We have been using partogram all the time. So we must understand the historical aspects of partogram to understand why we want to change. Thirdly, to look at recent research on labor progress curves and why we should change. And finally, suggestions for management of labor guide in the future. How do we really implement that? And conclude my talk. The main reason we want to change is because the cesarean section rates are rising all the time in all the countries, but there is no significant change in morbidity or mortality in terms of perinatal and maternal outcomes. So there is something that we are not doing properly with management of labor. And if you look at it globally, if you take India, for example, the section rates is supposed to be 10 to 14, or in some places 5 to 10%. That is because if you take big cities like Delhi or Mumbai, there's a high section rate, 40%, 30%. But when you go to the rural area, that's small, 2%, and so it equates. But nevertheless, why should we have high section rate in big cities? So we had to reduce the section rate because it doesn't improve the perinatal outcome. This is a global overview of the countries which belongs to the Organization of Economic Cooperation and Development. And as you could see, 27% is the average section rate, which is in the red bar. And those countries who have 40 and 50%, there seems to be more private obstetrics. So they must be doing for financial reasons. Or they have more litigation. So they might be doing for fear of litigation. And thirdly, there might be less counseling of the women to explain them the risks and benefits of cesarean. So the woman in labor says, please do a section. And the mother or mother-in-law also says she's suffering, do a section, and they do it. So we have to change that attitude. How do we change it? Whereas if we go to Sweden and Iceland and Finland, there are low section rates because there are national health systems, there are national guidelines and organized training. So we have to bring a change, but we need an instrument to bring that change. And that is what I'm going to talk about as labor care guide. These are papers from Betran from WHO, who studied the cesarean section rate in large population-based countries and showed there is no significant change in the maternal mortality per 100,000 or perinatal mortality or neonatal mortalities per 1,000. As you could see, the horizontal axis is the cesarean section rate. And once it reaches about 15%, there is no change in reduction in the maternal mortality or perinatal mortality. So the WHO came with the notion that 15% should be the ideal section rate. But it doesn't mean causation, because we don't know if it goes beyond 30%, whether it becomes a better perinatal outcome. And WHO looked only at mortality. What about morbidity and pediatric outcomes and psychosocial well-being of the mother and the baby? So these were not studied when they studied the section rate. So they revised their advice in 2015, and they said WHO does not promote any specific rate, but to provide cesarean section to all women in need. And they wanted the Robson classification system to be brought in each country so that they can decide which is giving rise to predominant cesarean section rate and we can reduce it. Now, Robson classification depends on 5 criteria: parity, onset of labor, gestational age, fetal presentation, and number of fetuses. So it has nothing to do with indication for cesarean section, but looking at the group of women who are likely to have cesarean section rate high. The number which contributes maximally is group 1, 2, and 5. 1, a nulliparous patient with single cephalic presentation over 37 weeks. 2 is nulliparous who has induction or elective section, and 5 is those who had 1 previous cesarean section. 3 and 4 are to do with multiparous women, and they have a low section rate. And if you carefully observe the 1, 2, and 5, 5 is because they don't give trial of labor, 1 and 2 because of mismanagement of labor. And the African countries have a high maternal mortality. This is called the ASOS study. And if you just leave the cesarean section to be high, they found that in Africa, the maternal mortality is 5.4 per thousand operations compared to 0.1 per thousand in the UK. So that's 50 times higher. So cesarean section has harm, and the numbers are so small, people don't look at it. However, we must keep in mind the cesarean section in Africa might have been done for ruptured uterus, bleeding before birth, placenta accreta, etc. So there might be other reasons for maternal mortality, but still it is high. So our principle as a doctor should be primum non nocere. That means we shouldn't do any harm. We should do beneficence. So if we have a deep dive why we are thinking about labor as the cause, this paper explains that the first stage of labor arrest, that is 15 to 30%, and second stage 10 to 25%, these are the main culprits for increasing the cesarean section rate, in addition to failed induction and non-reassuring fetal heart rate. So if you can manage labor properly, including good auscultation of the fetal heart rate, then we can reduce the section rate by 50 to 80%. So management of the labor is the key. So as I mentioned, management of labor, especially in nullipare over 37 weeks or in spontaneous labor, and those who had elective section or induced labor, and those who had repeat section. So we go back in history to Friedman's labor graph, and this was what was taught everywhere, and everybody thought there was a graphic analysis of normal labor. But when you read the paper carefully, there were 68 forceps, 1 cesarean, 4 pitocin induction, 15 augmentation. So by no terms, if you look at the original paper, this is normal labor. This is something delayed labor, and they needed instrumentation and oxytocin. And the second mistake we made is we not only misconstrued that as normal labor, but Friedman correctly said that 1 centimeter per hour is the maximum slope. As you could see, the underlying portion here is maximum slope. We thought that was the slowest slope, so we always put 1 centimeter for the alert line. Now, Philpott in Zimbabwe decided to use the graph produced by Friedman, and he looked at the different cervicogram, and they wanted to really prevent women in long labor and develop fistulae, vesicovaginal fistulae. So they decided they will take the Friedman curves, but also although they took the Friedman curves, the rate of cervical dilatation of African primigravida was much less than they thought. So he said, we tried to establish the rates of cervical dilatation in normal African primigravida to be similar to the pattern described by Friedman, but we couldn't apply this curve as a yardstick against to measure progress. This proved to be not to be the case. In other words, they were dilating much slowly. So he decided 1 centimeter is the maximum slope. Anyway, he used that 1 centimeter, but instead of using only that line, the alert line, he draw a line 4 hours to the right called the action line. So if they cross that 1 centimeter, they are made a note, and if they cross the 4 hours, then they will be transferred to a good unit where they can do a cesarean section. Now, on the opposite side, in Western countries like Dublin, Kirian order is called promoted active management of labor, but he said 1 centimeter per hour, and if they don't dilate as to the left of the 1 centimeter per hour, then you must rupture the membranes and give oxytocin. As a result, he augmented 55% on nulliparous women. So oxytocin infusion rate was very high. So WHO, in the midst of all this confusion, decided to have a look at it, because the Western country says 1 centimeter and Zimbabwe says 4 centimeters to the right, and which should be applied. So they decided to have a working group in 1987, which I was part of it. And we decided to do a trial comparing these in Indonesia, Malaysia, and Thailand. And the principles was, if there is left of the alert line, no action. So if it is left of the alert line, right of the alert line, transfer from peripheral unit. And if it reaches the action line 4 hours to the right, then you artificially rupture the membranes and give oxytocin. And regarding prolonged latent phase, we said 8 hours, but we can allow the staff to decide what is the best. And this partogram for WHO was done by myself, Barbara Cost, and Christopher Lennox, and was adopted from Philpott's partograph. That is the alert and the action line and the latent phase. And these were the countries. Indonesia, I was in charge of 2 hospitals, Thailand, Ken Stewart, Malaysia, Chris Lennox, and overall Barbara Cost. And we followed the principle that unless she reached 3 centimeters, not to intervene, and at least give 8 hours in the latent phase. And in the active phase, if it is less than 1 centimeter per hour, and if it crosses the 4 hours cutoff line, then we can do an ARM and give oxytocin. Now, the paper of the study was published in the Lancet. This is about 35,000 women. It was a semi-wedge randomized study, so it was not included in the Cochrane analysis, but it showed that the augmentation rate was reduced if you use a parogram, and from 20% to 9%, so less women had oxytocin. There was a slight reduction in cesarean section rate and also stillbirth rate. So this got adopted as a uniform standard after this particular study in 1994. Till about 2002, when Zhang raised the issue, well, we are using parogram, but the section rates are going up, so must be something wrong with the labor curves. So he looked at a retrospective 1,320 nulliparous women, and he thought the active phase, where it dilates from 1 centimeter per hour, starts at 5 centimeters, whereas Friedman was 3 centimeters. So there was a difference, but people would not take it straight away. So he continued and looked at 62,000 women. So these are retrospective analysis of nulliparous women, those who had delivered 1 baby and 2 baby. And you can watch carefully in all these 3, whether they are P0, 1, or 2, the active phase starts at 5 centimeters. So they said we must start the parogram at 5 centimeters. And numerically, if you look at it, if they want to dilate from 3 to 4 centimeters, it takes median of 1.8 hours, but it might take as long as 8 hours. So please keep that in mind, 8 hours. So you can give in early labor long time for it to dilate, because that's the 95th centile. 4 to 5, 1.3, and 6 hours. 5 to 6, as Zhang mentioned, it dilates at 0.8 centimeter per hour, and the 95th centile is 3 hours. So if you're going to construct another parogram now, you would do the alert line at 1 centimeter starting after 5 centimeter, and the action line 3 hours to the right. And that is about the labor care guide. You give as much time as possible in early labor. The American College took that into consideration, and they said prolonged latent phase should be 20 hours in nulliparous and 14 hours in multiparous. So completely different from the 8 hours of the WHO. And they also advocated 6 centimeters to be considered at the start of the action line. And they said they must give 4 hours, at least 6 hours of oxytocin infusion. Now, this has been studied in 1987 by myself and our team in Singapore. And we also mentioned that you must give 6 to 8 hours of oxytocin prior to decision for C-section if you want to achieve maximal vaginal delivery. So WHO, because of the Zhang spartogram and so forth, decided to reinvestigate the whole program. What they did was they wanted to look at research, do some original research for better outcomes in labor difficulty. They want to synthesize all the different labor curves which are published, and also wanted to see what does the women want. And they also wanted to look at what are the tools that can be used, and then introduce the intrapartum care guideline. So they wanted to research, original research, synthesis of evidence, look at the knowledge gap and how do we implement, and that was called Passport to Safer Birth. And they developed this protocol called the BOLD study, Better Outcome in Labor, and WHO BOLD project. And they studied, and this was the results, in 10,000 patients in Nigeria and in sub-Saharan African countries, in Uganda. And as you could see, the dark lines which are appearing are the labor curves. So they didn't intervene, they just let them dilate and see what happens. And you can see the line is from 4 centimeters is drawn 1 hour to the right. And vast majority of them are dilating much slower. Some of them are going to 15, 16, 17, 18 hours. And if they construct the labor curve, only at 5 centimeters, it is becoming 1 centimeter per hour. So they decided this is in nulliparous women, and in multiparous women, you can draw it separately how the labor curve goes on. So this is in P1 and P2. Again, quite a number of them are dilating at a faster rate. But if you look at the active dilatation, it starts at 5 centimeters. In other words, we should really move our current belief that active phase starts at 3 centimeters to 5 centimeters. So this is actually 10,000 women, whether they are nullipare or multipare, showing the same curve. Now, if you put the same curves into the existing WHO paragraph and look at the alert and action line, you could see that the labor curves come on as it is, and as you could see, quite a number of them cross the alert and the action line. Now, these are women who had good outcome. That means the mother and the baby had good outcome, and there was nothing to worry. So that demonstrates that we can give a longer time, instead of the earlier thought that you mustn't allow the sun to set twice on a laboring woman. If she's having a latent phase of labor, you can give more time. So this is those who had good outcome. Now, in the next slide, I'm going to put those who had poor outcome transpositioned against those with good outcome. And those lines will appear as red lines. And these are the ones who had bad outcome. And if you had poor outcome, perinatal outcome, not only those who had slow labor, but those who had quick labor also had poor perinatal outcome. So in other words, the cervical dilatation pattern is a poor predictor of severe adverse birth outcome. This was the BOLD study conclusion from the WHO. So they concluded our findings suggest that labor is an extremely variable phenomenon. Assessment of dilatation over time is a poor predictor of severe adverse birth outcome. Validity of paragraph alert line based on 1 centimeter should be reevaluated. So that was published in 2018. Now, I mentioned there was a systematic review of all the parograms available, and this is by Zhang, Suzuki, Shi, Zhang, Oladapo, and so on. And if you look at it carefully, for dilatation from 2 to 3 centimeters, this is in nulliparous women, it takes at least about 8 hours. This is 10 hours. 3 to 4, it takes about 4 hours, and 4 to 5, close to 1. And after 5, it is 1 centimeter per hour. And then after that, it is less than 1 centimeter per hour. And the same will apply to parous women. 3 to 4 takes about 3 hours or so, 4 to 5, just over 1 hour. After 5 to 6, it takes 1 centimeter. So this is based on number of studies. So if you take the BOLD study or a systematic review, it's the same answer. 5 centimeters should be the starting point. Now, I said there was some qualitative analysis, and qualitative analysis of women, they said they want a normal birth without intervention. We must have a healthy mother and baby, and we need support from a birth companion who can be mother, sister, husband, desire to be in control. So all the decision has to be discussed with the woman and come to conclusion. and sensitive, caring, kind, respectful staff. So WHO wanted to put these things into the paragraph. That's why it can become a labor care guide. So the components are respectful care, communication, so we should tell the woman what is happening. Labor companion, it can be mother, sister, but they will act as an advocate and go and tell the patient or the staff, my sister needs a review or my sister needs something. Give them fluids to drink, eat, massage, reassure, and so on. So labor companion plays an important role, and they should be trained to do that. Essential physical resources, not only the bed, but the toilet facilities, and to avoid overcrowding, and actionable information that the medical record should have about the fetal heart rate, partogram, the cervical dilatation. So all this has to be combined for labor care guide. The reason they wanted to shift from labor care to paragraph to labor care guide is also based on Cochrane review. As you could see, the review found 11 studies which met the inclusion criteria, 3 which compared paragraph with no paragraph, and 8 comparing different designs. In the 3 studies comparing paragraph with no paragraph, there was no evidence to suggest standard use of paragraph was favorable to no paragraph. So using a paragraph is of very little value according to the Cochrane. Now, they also looked at the latent phase, and they looked at the one paragraph without latent phase, and that demonstrated cesarean section and oxytocin were higher when the paragraph included a latent phase. So they wanted latent phase to be taken out from the paragraph, and WHO did that after this Cochrane review. Now, I mentioned about Zhang and whether Zhang's paragraph would do better. So in Norway, they did the randomized control study, which was published in 2019, comparing the intrapartum cesarean section using the paragraph of the WHO compared to Zhang's guideline. Although there was an overall decrease in both groups, there was no specific benefit in Zhang's group. So just using a labor curve alone is not enough. You must add the companionship, respectful care, etc., to make it better. So that is the principle of the WHO intrapartum care guideline. And these are the definitions of the latent and active phase. The latent phase is a period characterized by painful contraction till they progress to 5 centimeters. And the active phase starts at 5 centimeter to full dilatation. And duration of the first stage of labor usually does not extend beyond 12 hours in the first labor and 10 hours in the subsequent labor. So from 5 to 10 centimeter, they are giving 12 hours. Unlike in the past, we gave only 5 hours or with action line 9 hours. So this is extended for the intrapartum care line. And what is not recommended is to intervene if she is just dilating to the right of 1 centimeter per hour. And minimum dilatation throughout active phase is unrealistically fast. And labor may not naturally accelerate unless it is 5 centimeter. And as such, you shouldn't use section or oxytocin before 5 centimeters. So it's very clear from the labor intrapartum care guidelines when to intervene. Now the question is actually, you have to have kind and competent staff who give respectful care, emotional support, effective communication, pain relief, regular labor monitoring, oral fluids, mobility in labor, pre-established pain relief, and continuity of care. So all this has to be put into one paper, one page, and that is labor care guide. And this has a number of components. So I'm going to explain to you the smaller components and finish my talk. The most important component is they have included what is known as alert parameters within this blue box. Suppose if there's a meconium where there is abnormal heart rate or poor dilatation, it becomes an alert line. So I'm going to divide this into sections. Section 1 has identification and admission. So name, parity, when he came in. The second part is supportive care. That is about companion being present or absent. So N is not available, A is available, pain relief, N is not available, oral fluid not given, posture, supine position is discouraged. So the alert parameters are given at the bottom of the labor care guide, and it is every half an hour you write this. And if it is not normal, and it cuts the alert, then you put it in red so you know what is happening. Section 3 is about care of the baby, about the fetal heart rate. If it is more than 110 or 160, less than 110 or more than 160, there are late decelerations, then that's the alert feature. Amniotic fluid, if it is thick meconium or blood stain, that's an alert feature. If it is clear, you put C, clear, nothing to worry. Fetal position, OP or OT is an alert feature because you expect delay. Caput or molding, 3 triple plus, is an alert feature. And similarly, maternal, pulse less than 60, more than 120, systolic blood pressure less than 80, more than 140, diastolic temperature, and urine protein 2 plus or acetone 2 plus. Now, the way of finding out whether late deceleration, you can do it by auscultation, but nowadays simple Dopplers are available which can convert the digital display into a graphic display. Section 5 is about contractions. If it is less than 2, that's an alert feature. If it is more than 5, it's an alert feature. And you put 3 or 4 or 5, and if it is more than 5, it is 6, you mark it in red, and it's an alert feature. Duration of contraction has to be more than 20. If it is less than 20, it's an alert. You have to observe, and more than 60, you have to think if she's on oxytocin to reduce it. Cervical dilatation, this is the most controversial part, because the others everybody will accept. And here you can see if she's going to dilate from 5 to 6 centimeters, then you can give up to 6 hours. 6 to 7, you can give 5 hours, 7 to 8, 3 hours, 8 to 9, 2.5, and 9 to 10, 2 hours, and so on. Once she is fully, then she is fully, and you have to do that. And descent, because in multiparous and nulliparous, there can be a sudden descent, there is no alert feature here. Section 6 is medication, especially oxytocin, and if there is any analgesics, IV fluids given. 7 is shared decision making in terms of what is your assessment, in terms of pulse, blood pressure, dilatation, and what's your plan. And the plan has to be discussed with the patient and the companion and written. And these are the alert features mentioned. If it is yes, where you put Y, N is no, decline D, U is unknown, supine, and so forth. And finally, the initial experience of the usability, accessibility, and feasibility of the labor care guide. Mixed country, multi-country evaluation has been studied and published in 2020, July. And they feel that it can be applied to many birth settings. And they provide this WHO labor care guide users manual, which you can download from the WHO site or type in the Google labor care guide manual, and it'll come. And they feel that's important because more than 1/3 of maternal deaths and half stillbirths and quarter of neonatal deaths results in complication during labor and childbirth. And the majority of these deaths occur in low resource setting and largely preventable through timely interventions, and monitoring of labor, childbirth, and early identification and treatment are critical for preventing adverse birth outcomes. So this is what they are proposing. And this book will give you examples how to use the labor care guide. So I would like to conclude that in India, maybe you can think about pilot studies to evaluate the feasibility of using labor care guide, because it's more intensive. So you might need more staff, and you might need private setting like curtains and so on for the husband or mother to sit in. So you must know the feasibility of that in your own settings. And once you know you can set it in, the second step for you would be to do a randomized controlled trial comparing the labor care guide with WHO paragraph. And I've given the website where you can get all the information. So with that, I'd like to thank you for your patient listening, and I'll be happy to answer any questions. Thank you very much indeed.